I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel Friends. We're here because everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is what's in and what's out with the new administration's healthcare plan. A lot of changes have happened, and we need better changes to improve the outcomes with COVID-19, especially with the vaccine rollout, as well as increasing access to healthcare. So tonight, I am so thrilled to have two very dear friends of mine, very passionate about healthcare, as well as healthcare policy. But first, Robert, how are you doing?
Hey, Faisel, how are you?
It is good to see you, Robert. Dr. Dan's going to be with me tonight. He's got a board meeting with the VAFP. Dr. Dan, I'm going to miss you, but we'll be okay. We'll be moving forward. And I know that this is a topic that he's really passionate about as well. I know he wanted to speak about this, but that's okay. We'll have plenty of time I'm sure, as things move forward, to bring this back again.
Right. Well, Faisel, so I know the sort of name of the topic tonight is what's in and what's out, and I'm going to make a little political statement here, but we heard for 4 years previously that there was going to be a healthcare plan, and people were wondering when that was going to be shown. It never came out. So the previous administration, I don't know what was in. There was a lot that was kind of out, but now hopefully there's some more stuff that's in. The one thing that the Trump administration did accomplish that I think will have pretty big ramifications is price transparency rules that they rolled out for a lot of healthcare facilities to be able to have to publish that and make those available. I have seen the rollout. A lot of facilities are publishing them in unreadable formats, and so they're trying to kind of circumvent the actual regulation and the purpose of it. Hopefully that rule gets adjusted and makes it more usable for patients. But first, I think since we're talking about policy today, it's important for us to kind of go through some of the kind of major insurance markets, because that's going to be a pretty big focus here. So tonight we want to talk about sort of the immediate term sort of health policy related to COVID. That's a big platform for the first 100 days of this administration. We know there's been a lot of sort of announcements, a lot of more centralization, a lot of funding that's been announced, and a lot of executive orders. And so that's going to be part of the discussion tonight. But first, let's look at what we have right now that we know about the Biden administration that's not related to the campaign. So we have a graphic. So can we bring that up? I love this Capitol building. I live just down the street, so pretty exciting. So there's a couple things that have already been proposed, and most of it is related to vaccinations. But what you'll see is that some of it, the legislative actions that have been proposed already and announced, are really going to be building on that Affordable Care Act. So the goal is sort of being able to increase insurance coverage and making sure that there is actually a good public option for people to gain health insurance, which brings me to the three major health insurance markets. You have Medicare, which is typically for people who are 65 plus. They become eligible when they turn 65. It's a tax that's been paid for people's entire lives out of their paycheck. And so they get there and they become eligible for Medicare. There's two ways that you can sort of take and receive Medicare. You can go through traditional Medicare, which is paid for and funded by the federal government. And then you can also enroll in a Medicare Advantage plan, which is also known as Part C. So that's Medicare, mostly older adults, but also people with certain chronic medical conditions and chronic kidney disease that are also eligible for Medicare. Then you have sort of the vast majority of people are covered by private insurance. So those are people who typically get insurance through their employer. And we in the United States have what's called an employer-based system. So most people receive their health benefits through that sort of relationship through those commercial insurers. And then there's the safety net program, which is actually a state and federal partnership. So the federal government pays a certain share of this to the states, and the states foot the rest of the bill. This is the Medicaid program. There's actually 54, 55 different Medicaid programs, such as in Puerto Rico, all the typical U.S. states, Washington, D.C., and Guam, and a couple other programs across the U.S. territories as well. But what this means is there's actually 50 different state Medicaid programs when you think about the 50 proper U.S. states. And so they all have their sort of differences, their quirks, their own policies that actually happen in state legislators. But what happened under the Affordable Care Act is there was this goal of sort of expanding Medicaid to cover people who didn't have employer insurance, weren't eligible for Medicare because they weren't old enough, and really didn't make, they made too much money to actually be eligible for Medicaid, which is that safety net program for people of low income and certain other disabilities and other conditions. But there was a group of people in the middle there we've kind of built this market around called the individual market. And so that's the small group market, the individual market, which was part of the Affordable Care Act. And so we know that the Biden administration is really going to kind of work off of that. And the question in the long term is, will there be further action to actually provide a public option for healthcare coverage? So now I'd love to turn it over to the guests to kind of talk about this. Right now, like I said, mostly what we know is sort of COVID response. And one specific topic we want to cover tonight is sort of what is the future of telehealth policy. We know that there's actually 300 bills that are on the floor in the states for telehealth action. So that's a pretty big number. And then we also know that there's a lot of rules that came out in November from the Centers for Medicare and Medicaid Services related to telehealth, all built partially for the pandemic response, but also something that's going to be here to stay going forward. So very excited to continue this discussion tonight. And, you know, I think the best place to start, because it's top of mind, I think we're going to go here anyways, is probably starting with COVID response. We've seen the most announcements from that. Let's talk about what's going on with COVID, and then we'll bring it back to sort of perhaps health coverage and telehealth towards the end of the show.
Sure. Great. We have two dear friends joining us tonight. We have from Virginia, Dr. Stephen Lewis. Dr. Stephen, how are you? Welcome.
Hey, doing great. It's good to be here.
It's good to see you again. And also we have Dr. Nehal Gheewala joining us from Florida, Tampa.
Good evening.
Hey,
guys.
How's it going? Thank you for coming back. Robert, I have to say that, you make healthcare policy sound so eloquent. I could hear you speaking about healthcare policy.
Oh, it's so fun. I spent a lot of time in that space until I ended up in virtual care and telehealth world. But yeah, I love it. It's really fun. I also am at the heart of it here in DC. And I do miss going to Brookings events that are open to the public to sit there and learn all the new stuff that's going on. So, it's been a little bit of a bummer not to also talk to my lobbyist friends at happy hour and things like that to hear what's actually going on the Hill. So, but anyways, really excited to hear what you guys think. So COVID-19, Trump administration handled it through 2020. New administration came on. What are we seeing differently compared to sort of the vast majority of the response?
Well, I can get started. I mean, there are a couple things that are just being continued. The national emergency, the fact that it's a national emergency, these things need to be renewed periodically. I don't know if it's every 90 days or every 6 months, but that needs to happen, and that's happening. That we need to renew that COVID-19 is a public health emergency. That's happening as well. I think that expires at the end of this month, on the 31st. But some of the really big news is that the U.S. is the United States membership in the World Health Organization. We're going back into the World Health Organization, which is great. And then joining COVAX. COVAX is interesting. It's an initiative that's designed to get all the resources together from countries from around the world to take on the coronavirus. I thought that was very neat so far as COVID is concerned.
Right. And I think in addition to that, working at the state level, the government's looking at a federal level to working at the state level to make sure that we have enough vaccines, make sure we have a preparedness plan. And a lot of the plans that we've had have, even at the states, they've it's varied. There's a lot of variation depending on what state you're in. They're letting local government really handle it. And no one's really following a particular protocol, which has led to a lot of confusion. I think most Americans were expecting some level of standardization.
Yeah.
That didn't necessarily happen.
Yeah, like a national campaign. That didn't happen. It was all state dependent.
You mean like
And
like leadership and a plan?
it's a little bit of a leadership. It's really important with all of that and the additional, the 25 billion that they're putting in with the goal of the 100 million vaccinations over, the next
Yeah.
100 days. All of that's wonderful, but they're really putting a focus on working with the equity and making sure that, there are certain proportions of our, society, obviously, that have been hit harder with COVID in general in terms of rates, outcomes overall. And so they're actually taking a specific look at those populations and trying to have an actual answer towards implementing that. And they're throwing money behind it. So I think that's really a good step forward in really addressing the inequity that we've seen with COVID rates.
There's an
Yeah.
actual task force, a COVID-19 racial and ethnic disparities task force, which is great.
Absolutely.
Well, I mean, many of these communities are the communities that we take care of. I mean, we are, community primary care clinics, and we spend a lot of time with these populations who are underserved, and they are the ones greatly affected by what happened in 2020 and moving forward. These are the communities that often get forgotten about. These are the people that don't get the things that everyone thinks that they get, and really they don't. And they're the ones who are getting really, really sick. It's the old, the sick, and the poor who are really affected by this.
Yeah, absolutely. So I think some of the things that I've seen, particularly given the work that I do on a daily basis, is what we're seeing from this administration is like really strategic funding and actual funding allocation to a lot of these really big issues. But there's also like actual planning and collaboration going on from the federal side. So there's coordination, there's communication, and they've just restarted the press briefings as well, so that the American people can get access to what's going on. It's not just the press secretary, it's people coming up there and talking about the science and what we know and trying to just make things actual open and transparent. But what I've actually seen at our company is just big expansion. I can't talk tonight. A big expansion of need for staffing to actually administer these vaccines, because they are being distributed and there is money that's going to the states to be able to come up with their own strategies to be able to distribute this vaccine, which at this point is our best chance at actually beating this and actually reducing the mortality and morbidity of the situation. So it's been very nice to see that. I know they also did a couple things that are really important that probably affect a lot of your patient population, which is increasing SNAP benefits by 15%. So not only are we seeing them dealing with the direct ramifications of this virus and trying to control it, but we're also seeing, trying to deal with the economic impact, trying to get more stimulus payments pushed out. That hasn't happened yet, but those SNAP benefits through an executive order increasing by 15%, that's huge for families that are struggling right now.
Yeah, absolutely. And I think it's great to hear that there's a big focus on the prevention and planning for future initiatives as well. So, I mean, the World Health Organization joining, getting back into the WHO is great, but also working with them to plan for future initiatives and future pandemics, because unfortunately, this is not going to be the last one. The worst case scenario is we have another pandemic that spreads this quickly, but is as dangerous, or the outcomes are going to be as poor as, the original SARS, where people were a much higher death rate, and now we have something that spreads. Combining that is going to be a pretty detrimental thing for the entire world. And so that we need to have much more of a push towards planning, not just as a country, but as a world. And so there's good to see that there's going to be that support for that as well.
Yeah, absolutely. I mean, it seems like we can think back to Hurricane Katrina, we can think back to a lot of these big public health disaster events that, like, we just are always fighting from behind. And I'm certainly hopeful that this and the current administration really focuses on, like, okay, we really do need to put these plans in place. We need to have the right people in the right places to be able to respond to these types of situations. We need surveillance around the world, and that means collaboration. So that's sort of a really big thing that I think is happening here. But I think what would be good now, we've talked about COVID so much this year, let's talk about the future of other health policies. Let's talk about healthcare coverage as sort of a topic here.
I've got a question here from Dr. Ajoy Kumar. Dr. Ajoy, how are you doing? Thank you for sharing your question. Let me put it up here, see if I can get it up here. Dr. Kumar was on last week, and he's got a comment question here saying that the big issue is while Medicare lowers the age for access, will Medicaid be further expanded? I've been reading
Yeah.
about lowering the age to age 60, which is quite exciting for people like my mother, who's turning 64 this year. Dr. Gheewala, get ready. You have another patient. He's already my father's primary care doctor. But what have you all read about Medicaid and the expansion of Medicaid?
That's,
Yeah.
oh, go ahead, please.
Okay, I was just gonna start us off. I've been talking a lot, so anyways, the potential one of the there's a lot of like policies that are being promoted for expanding coverage in particular, because in the United States we still don't have a full covered population, so there's still a gap. About 10% of the U.S. population at any given time doesn't actually have healthcare coverage. So the ACA, the goal of the Obamacare, the Affordable Care Act, was to actually give a pathway for 100% of the U.S. population to have some sort of coverage, and that means paying in and having a risk pool or being subsidized or being a part of the Medicaid expansion population. So historically, Medicaid in all the states were really only able to cover a certain percentage of the federal poverty line. So that in some states could be people who make up to $20,000, it could be up to $16,000. But the ACA, the goal was, okay, let's expand that up to an expansion population that could be up to 400% of the federal poverty line.
Wow.
And so for the federal government was actually going to cover that full expansion population. What happened was a lot of states, particularly conservative states that were kind of run by conservative legislators, did not accept that federal funding to expand Medicaid. And so there still was a coverage gap. I think the coverage got close. I think it got up to like 94, 95% during the peak of sort of Obama's second term. But what ended up happening was some of those states didn't expand Medicaid, so there's still people caught between the employer coverage gap. They work for small businesses or they work for a couple different jobs and they just don't actually have access to full-time employer benefits and weren't eligible for Medicaid. So then there was sort of this population that was eligible for the marketplace. So that's like healthcare.gov, going there and looking for subsidized plans based on your income. And they were provided by your typical health insurance providers, United Health Group and Anthem. And they're able to go on there and create this individual market because there's an exchange. And some of those would have federal subsidies where federal government would pay for part of it once your income was verified at being a certain percentage. And so what some of the other policies that are really pushed are like, okay, let's actually reduce the age for Medicare so that you get more people on Medicare. You reduce some of the cost burden for some of the older people on insurance markets and kind of let them sort of expand down into that individual market. So that's one. And then, I think what we're probably going to see is potentially trying to build off of that ACA goal of trying to get Medicaid expanded. The problem with expanding Medicare is the cost thing. So you're going to get a lot of pushback in Congress where it's like, that's really expensive to expand eligibility for something that people call an entitlement.
There's definitely going to be a lot of pushback in terms of lowering the age for Medicare. I mean, I think that would be very beneficial, but I'm not sure that in this climate that's going to be something that's going to happen anytime soon. Though the other part with the Medicaid expansion, so I think the plan is to extend the subsidies for all the people that would qualify under the expansion in other states. If the back and forth and negotiations are going to be in the states that did actually expand Medicaid on their own, they're going to end up paying more money because they've expanded the Medicaid, and the government is going to provide subsidies for all of the other states that didn't expand. And so the states that chose to expand Medicaid, they're going to have some type of negotiation because they're not going to want the benefit to go to all these other states that didn't have the expansion. So I'm sure there's going to be plenty of ways to work on the subsidy and provide additional benefits for those states. But that's going to be something that's going to be really contentious when they start to try to work out those subsidies.
Yeah. And at the end of the day, however it happens, right? Public option, Medicare for all, Medicare Advantage for all, expanding Medicaid's, age eligibility to try and capture some more people, expanding Medicaid. The goal is actually to close that gap of people who don't have funding or don't have coverage and therefore give them access to primary care, right? So it's not just like, okay, let's just give people coverage. It's, okay, we want them to have access to that. And then wherever they're getting coverage, we want them to actually be able to go to their PCP, have that funded, and have that coverage to be able to get that preventive care. That was the whole goal of the ACA. And I think what we're going to see is the Biden administration really jumping onto that and trying to bolster that and potentially try and work with some of the states to try and come up with some creative arrangements where like, okay, let's just try and get this coverage here, because we are the only developed country in the world that doesn't have a mechanism to actually provide health coverage for the entire population. And that's where we often have really high expenditures and and much sicker folks, because a lot of times they can't get access to healthcare, or they don't have a PCP because they don't have healthcare coverage. And at this day and age, it's starting to get really old to me. It's like, come on, we can do this. We know how to do it. We have mechanisms to do it. It's just this ridiculous political thing, and it's like it actually benefits us all. And so I'm sick of it. I'm tired of the discussions. It's like we need to just have a reasonable coverage mechanism for everybody, and that solves a lot of problems.
I mean, the rest of the world must look at it. They must be so confused that in America, half of all medical care is delivered in the emergency room setting, and you have all these doctors. You've got nurse practitioners. I mean, we've got so many people ready to take on primary care and really just deliver efficient, quality primary care. But the system isn't there to support it. The system rewards, like we have 800,000 specialists, 200,000 primary care doctors. We have half of all medical care being delivered in the emergency room setting. So when we're talking about increasing access or increasing, especially the people who are unfunded, allowing them to be able to get their care at the primary care setting. Because otherwise, when we're looking at it through the lens like, hey, they're going to continue going to the emergency room and, we'll end up paying $10,000 for these $7 pneumonias. That's not the way that should be looking at it. How many patients do we have at ChenMed that they turn 65 and that's the first time that they actually have insurance or they have health insurance coverage? We see it all the time. And they come in, and they're completely mismanaged. I think about all the insulin-dependent diabetics who were started on insulin in the emergency room setting with hyperglycemia, and it was just refilled. Some of them for decades, they've been taking insulin, and no one ever spoke with them about the lifestyle changes, basic changes they can make with their diet, even offering oral medications. I remember that was one of my biggest shocks when I joined ChenMed, being a full risk doctor, was how we were able to wean off so many insulin-dependent diabetics off of insulin, because we were the first time that they actually had access to primary care.
Right. I mean, I think, the goal here moving forward is to give Americans a choice, like Medicare, something similar to it, and to lower costs, like you're saying, somebody who's been completely mismanaged for years, just getting insulin, going back to the ER, it's bad for their health. Absolutely. That's the number one thing, but it's also bad for costs. I mean, you're losing money and you're not improving anybody's health outcomes. So you're not winning at all. So, giving, people a choice, you have to give them options, but you have to have all the options. You have to have an employer, private options, public options. And I think, the goal moving forward is to increase coverage to lower income Americans. There are states who did not expand on the, regards to Medicaid. And I think the goal moving forward was to expand eligibility, Medicaid eligibility of the ACA, and have a broad public option. And one of the things I was reading up on, is that there should be, they're proposing and moving forward with a tax credit for those families who make between 100 and 400% of the federal poverty level. And they're actually thinking about moving, I think they already moved forward with this, moving the 400% ceiling on that. So, that kind of raising the bar there so that, lower income families have a little bit more chance at getting a greater coverage there. And the tax credit sizes can also increase. Again, it depends on where they are in the federal poverty level, if they're in an individual or in their family size. But, there are still many families that with between 100 and 400% that still struggle to afford basic healthcare insurance. And even moving forward, middle-class families will also get a tax credit. So these are just, some innovative ideas, but we have to get down to the basics. And the goals, of course, are, increased coordination of care, increased quality, and controlling the cost. It sounds pretty similar to Medicare Advantage when you think about it.
Yeah. Well, and you bring up a really good point there, and one of them is that it's not just the lower income folks we need to expand healthcare coverage to, but these subsidies really benefit people of middle income as well, because healthcare costs are so expensive. I mean, it can cost $20,000 a year to, provide healthcare coverage for a family of four, and that's a lot of money. And at the end of the day, even people making more than the 400% of the federal poverty line are unable to afford premiums if they go to a health insurance provider themselves. So these subsidies in this individual and small group market really are designed to help solve that problem. And I always like to bring it back down to what you three are experts at, which are, the coverage is one thing. Giving somebody healthcare coverage, by the nature of giving them healthcare coverage, doesn't do anything. You need to make sure that they're actually getting care at their appropriate location. For a lot of people, the reason why people go to the emergency department is because there's this law called EMTALA, and they really have to be seen there. And so if you route people to a long-term PCP because they have healthcare coverage, like at ChenMed, those patients get longitudinal care. They get chronic care, which are our biggest drivers of costs in the country. They try not to show up to the ED anymore. And they're managed by physicians like you three. And you sit there and you help them get better health. And therefore, your return on investment for that coverage is really, really strong. So it just makes a smart economic argument. And Dr. Kumar brought up a good point here. Can we bring up Dr. Kumar's point here? Yeah, so we really need to take healthcare off the bargaining table. For some reason, it's a political tool, and at the end of the day, it's people's health. It's the health of our country and our citizens. So regardless of whether you're a Democrat or a Republican, it's the health of everybody. And what's really important to know about that is that it pays dividends. If you invest in health, this is an investment in the country. This is not like a political tool. Like, we're not choosing between investing in solar farms or like wind farms, right? We're choosing health of our citizens and the society to be able to go and have more productive work days, and to not be spending a ton of money with people in the hospital, and have a happier and healthier population, which pays economic dividends for everybody. So it's something that really does need to be taken off the bargaining table. It's not a political tool. It's not a policy. It's something we all benefit from.
Right, and it should be cost effective. It absolutely has to be cost effective moving forward. I mean, there's no point of having something that is high cost, high deductible, no access to care. I mean, you're just treading water. You might actually be going backwards.
Yeah.
And really, with something that we should be all looking forward to is that the tax credit sizes might also increase. So for lower income families and even middle class, that's something that can really help them afford something, so they can do something with it. It's affordable, outcomes-based healthcare that's really going to kind of change things here in the United States.
Yeah, I think we need to move away from using just healthcare in general as a commodity by itself, just acting as if healthcare is something that we don't want as a society, some people to get for free and others to have to pay for it. We use it as this singular item that we have to distribute, and that's not the case. Because eventually, if you have enough people that are not getting good care, that are always sick in the hospital, oftentimes are bankrupt and not able to pay for that care in the first place, then you're ending up having to pay for it from some other source, whether it's taxes, whether your state is end up, getting bankrupt and not able to pay for other things for your park and, recreation. It's coming from some other source. And it's not, that singular commodity. And, there's been a lot of backlash for the thought that we're decreasing the cost of your total income for what you're spending on your insurance from 10% to 8.5%. There's actually been backlash and negative about that. And that's a simple change to just help people that are working, that are mostly middle class, to be able to get some good insurance for their families. And then also that's going to stop the young, healthy people from leaving the marketplace, so that they're included, so that we can decrease some of these costs. Because that's essentially what happened with the ACA when it came out. All of the young people, particularly when the mandate was ended, all the young people kind of backed out into these really high deductible plans, and that made the cost go up. And the system needs those people in order to decrease the cost overall. So I mean, at this point, some of those high deductible insurance plans, people have them. We're going to have to work and try to support them in transitioning over to something that's a little bit more tenable. But it's those simple changes in the policy and that thought process that can make a really big difference.
Yeah, absolutely. What's real? I had a professor in healthcare in America was the class it was called. He was a Medicare physician, and he always used to say it's not a zero-sum game. And a lot of people always think it's zero-sum game. You take money from the insurance companies, you give them to the doctors, you take it from the doctors, you give it to the insurance company, but it's not. It's if you improve health, you reduce demand for healthcare services. So if you make the investments in the right places, primary care, and health education and equity that exists, being able to solve some of those social determinants of health, work and try and root out poverty and societal inequity, those types of things actually drive a whole lot of our healthcare spend. And so if you route the money to effective social programs, to effective healthcare programs like primary care, it's not a zero-sum game. You're not going to just end up spending more and adding on to it and take it from somebody else. You're actually improving it overall. Now, the problem and the reason why it needs to be done through legislation is that the private market won't be able to do that because you're taking money out of the system. So when you do make an investment, you have to do it from a societal standpoint, from a government standpoint, because the private companies will never do that in such a way that they end up taking money out of the system unless they're incentivized to or forced to conform to new policies. That's really, really important.
There's some plays that are going to be long-term plays. I remember when I read about the impact that the pregnancy Medicaid had over the last 30 years with the children of women who received Medicaid access. These children ended up attaining higher level of education. They get better paying jobs, and they pay taxes to the system. So there are definitely some long-term plays, but we know already. And I think with the price transparency, especially for the hospital systems, I think that's why it's so complicated. I mean, it's complicated because once people realize that so much of the medical care, the waste of it all, when you're literally talking about $1 out of $3 spent is medically unnecessary, and that's just starting, and that's driven by the unnecessary emergency room visits. Most patients don't get direct admitted in the hospital. They get fed in. The vast majority of them get fed in through the emergency room system. But once we start investing into primary care, we start using technology, and we haven't even gotten into telehealth, like the explosion of telehealth and what we've learned with telehealth, even with geriatric care. How many people appreciate this is the time. The culture is here now. It'd be interesting to see what happens with all the licensure requirements and restrictions. I'm looking into residency rotations. And my God, it's like every state, it's a state dependent thing. I can't just go and say, hey, we got clinics in 12 states and there are 1,400 primary care, internal medicine, family medicine programs. Let's start letting these residents rotate through. It's a state dependent issue. I was exploring to see if I could provide geriatric care from Florida, sitting here in Florida, to geriatric patients in Virginia Beach. And my gosh, the process, I got to apply for the Virginia state, I got to apply for another state license and go through all of that hassle and headache. Mm-hmm. One thing, if I could dream and hope for, is that we don't have to deal with all of those headaches from having to deal with paper and fax. I mean, for God's sake.
They waived it during COVID, right? They were like, oh, you can practice across state lines now because it's an emergency. And they're like, oh, no, we're going back to it now. And it's like,
they did it.
Wait, we can do it during the emergency and it's good then, but it's not good for patients during normal time, and it's not good for the physicians during normal time. The reason why it exists is because the states make money off of it. Medical boards make money off of it when you have to get their licensure and pay their fee. So that is a very strong influence on the policy for that. And so it comes back to the money in that case. So what do you guys think is going to happen with the telemedicine stuff? I mentioned earlier that all the states are kind of doing their own stuff for Medicaid and for some of their other insurance markets. There's 300 bills across the country on state legislators about telehealth. And then the federal government has released a bunch of rules for remote patient monitoring and telemedicine, and has improved sort of parity and payment rates and things like that. But I think we're still waiting to see what the administration's going to do. So what do we think is going to happen?
Well, I think it's really going to take off. I mean, it already kind of has. And you touched upon a great point that during coronavirus, when the pandemic was really, picking up, doctors could cross state borders. The volume of telehealth was there, and they just didn't have the volume of providers. So depending on what state it was, so they had doctors working across state lines to help people, which was a great idea. And I think, moving forward, this is going to be fully embraced. This is a model that can increase access to between patients and doctors. But really, I think the key is still having continuity of care, not, having that ER feel where going on telemedicine, you're meeting a different doctor every every time you go, it should be, you should still have a primary care doctor. And I think it still should be local, if you can have if there's an option to have a physical exam in person with that provider. Of course, that would be ideal. But to have telehealth with continuity of care together increases access, lowers cost. It's really about prevention. It's about identifying things early. You can't prevent a hospital admission. You cannot do anything about it. At that point, it's already too late. The key is prevention. What can you do? And all of us, I'm just speaking generally, what can we do to keep them from stepping foot into an ER? Well, I mean, when the ER gets some of these people, I mean, they don't know what's going on any different, but the difference is they have no continuity of care. And imagine if you can find out that someone's saying, hey, I'm having XYZ symptoms, and you diagnose them with diabetes, with some labs, you order a few tests, and then you follow up, you prescribe medications, you lower cost really in the long term. You improve their quality of life. You're focusing on prevention, and you're really preventing those hospital admissions, those hospital sick days, and giving them more healthy days. And starting this, expanding this to a younger population. Imagine, this younger population who uses technology, embraces technology, and you're now showing them telehealth and incorporating that into their lives earlier can really improve health for the younger generations as well.
Yeah, I think that's probably the most important point, is that we really have to make sure that it's tied to really high level primary care. And if specialists are doing it, they're really evaluating, those patients that really need the specialty care. The concern that I have, and maybe part of the reason why there was a little bit of a backtrack on the expansion, is if you don't have really strong primary care, then you can have one provider having 10 to 20,000 patients under them as a PCP, and then they're not providing that quality care. So we really have to make sure that the telehealth expansion and that we're all really excited about, and that we've been able to use so much at ChenMed, and provide really good outcomes, that for the rest of the population outside of our patients is going to be something that's effective, and that we're not actually creating new health disparities because we have populations that don't have really good internet or broadband access, that are really far away from their potential PCP and are not going to get evaluated, and having multiple telehealth visits without being able to properly assess their care. And I think that all of that is very possible if we're really utilizing this the way that we all hope it's going to be utilized, and that we're making sure that people are not creating those new disparities and inappropriately using the expansion of the telehealth system.
Yeah, absolutely. Yeah, there's definitely, you have the major like direct to consumer telehealth folks, which are your teledocs, your Amwells of the world, and a lot of times you do get routed to a new doctor every time. And what they're trying to get to is sort of a more continuous chronic care model. They know that they need to do that to keep that continuity in place, both for the patient, but also it makes sense from a revenue perspective. What we did see during COVID is a lot of places like ChenMed really accelerating their use of telemedicine, which is, I think, probably the best use case, where you have that PCP relationship, that established patient, where they still come in to see you, but you're also providing telehealth services which are more convenient, and better for the patient. They don't have to travel as much, so you don't have to pay for travel, and they can actually still see their clinician or their physician more often. And I think that's going to really grow. I've heard through some of the work that we do that most health systems are anticipating about 20% of patient visits are going to go virtual. So about 20% of them are going to be either for follow-up or initiation visits, or just kind of whatever mix, are going to become virtual or telemedicine based. So that's the number I've heard thrown around, and that's sort of the equilibrium that most places are kind of shooting for at this point in time.
Right. Yeah. And one thing I wanted to add, Robert, is that a thing that has been brought up is, well, we're saying telehealth, but what about the technology? What about the people who don't have the technology? We're talking about lower income Americans that might not have a smartphone. They might not have a computer. And how are they going to increase access to care? Even if you provide the service to them, how can they get it? So there's been a lot of talk and a lot of groups that do this, including us, just deploying technology to the patient, giving them something to use that they can use temporarily for their visit, or they can just kind of hang on to, and they use it to communicate with their doctors. We've done it with seniors, and we've done it successfully, and seniors love it. And Anyone who ever thought that a 90-year-old couldn't get on a telehealth visit by themselves, think again.
That's a
They've gotten very.
I in my new book on virtual care that comes out hopefully in the next couple of months, I have Faisel in there quoted talking about one of the patients that he provides care for, who was like 70 or 80 or something like that. So yeah, I get that question all the time because I talk about virtual care constantly. And what I get constantly is like, oh, older adults will never use this. Like, they don't even know how to use it. And I'm like, sure, there's a little bit more of a learning curve, but I was like, I hear from my folks, my friends at ChenMed with the older, dual eligible population that they're doing it just fine. And sure, there's always challenges. And now the fortunate thing of being in the full risk model is that you can give devices to people and you can fund that. Whereas I think the fee for service folks would probably have difficulty paying for that without a grant. But I think with the growth of the full risk model, we're going to see really telemedicine and virtual care kind of blossom with being able to actually solve some of those technology access issues. So what's our wrap up here? I think we should go through. Faisel, you have some stuff to say, I'm sure, but why don't we all give sort of our key takeaway, or what we expect to see from the Biden administration? What's one policy that you're excited about, I guess, that you hope to come out of this?
With me, starting with me.
Yeah. This is Faisel and Friends, right? I'm friend, you're Faisel.
Usually I'm the last to go, but thanks. I'm thrilled. I am thrilled about several things. In particular, I'm thrilled about daily briefings from healthcare people and science, like people of science. I'm very excited about that. I'm worried about the distrust in just people of authority that has happened over the last couple of years. Just the extreme distrust. We see that the major driver of unnecessary medical care is a distrust. It's patients who don't know. If they can't trust their physicians with the little stuff, how could they trust them with the big stuff? So I'm looking forward mostly to people having trust and faith again in people of authority, people of science, people who've dedicated their lives, especially when I think about physicians and primary care. We have dedicated so much of our lives to studying medicine. I recently, my 13-year-old showed me a physiology lecture on the cardiac cycle. And it was this detailed lecture on everything that's involved with one heartbeat. And he was just blown away about how detailed that was. And I said, well, yeah, there was a time I remember, it was 12 hours, 14 hours in the library studying these things for years. And then going into residency and doing these crazy 16-hour, 30-hour shifts. And then we get to this point where we can actually do something, especially with prevention and delivering efficient care. And it's like we come out into this world where the people don't trust people like us who've gone into primary care. And I think about, especially the three of us who've become doctors, primarily in community health, going into, underserved communities across the country. We're not like, if you think about where ChenMed centers are, they're not next to the country clubs. They're in the areas of most need. And people like us believe that, hey, we're the area of most need. That's where the greatest opportunity is, for us to fulfill our life purpose. So I'm most excited with this new administration, hopefully about restoring trust in at least some sacred professions like medicine.
All right, Dr. Gheewala, you're up.
All right. So, I think, I'm really excited about, the possibility that we're really inching close to really expanding coverage to lower income Americans, really focusing on cost and focusing on outcomes, really doing kind of a Affordable Care Act Part 2, really building upon that and seeing how far we can go. What can we do to really improve the health of these pockets of, people that really don't have any access to care? And how can we do things better, stepping back? And I think, having especially something like 2020 really happened to everybody. We have a lot on our minds, and I think that a lot more people will be on board. Thank you.
All right, Dr. Lewis.
So, my area of most excitement is really around medication costs. I'm excited about the expansion and everything, but specifically around Medicare being able to negotiate costs for medicines is huge. It's not going to drop down all costs, but it's a really significant ability to negotiate those costs. And I'm really hoping, I hope the pharmaceutical lobby doesn't end this effort, but around changing patent law. These pharmaceutical companies should not be able to extend their patents on medications or just reproduce the same medication and it be able to stay on for these high costs when honestly they don't cost nearly that much to make and shouldn't cost that much for patients. And there hasn't been any effort for, I don't know, multiple administrations to really address patent law. And the lobby has been able to continue to make these changes and extend the patents for the same medications to get additional patents. And that has directly contributed to very high costs and lack of accessibility for a lot of our patients for some of these medications that can be life altering, life saving. And so some of the specifics around the medication costs are really exciting. And I hope that they actually come to fruition over the next 4 years.
Yeah, that's something that's been a big thing that people have been advocating for a while because our government's not allowed, or our government health programs aren't allowed to negotiate and kind of bulk purchase drugs. The UK does it all the time. So
Right.
NHS is able to bulk purchase drugs based on what they think they need, and they pay a considerable, like double-digit percentage less than what they sell the drugs for in the United States.
Right.
It's remarkable. That's a really good point. Thanks for bringing that up. All right, Faisal, take us out.
Wow. That was a great discussion. Dr. Gheewala, thank you so much. Dr. Stephen Lewis, thank you so much for joining tonight. Robert, you're so eloquent with talking about healthcare policy. I just absolutely love hearing you speak. This was a great discussion. To the comments, people giving the comments, thank you so much for your comments. Dr. Joy Kumar, gosh, I could have had you on tonight as well. We'll definitely have you back again. Great comments. Thank you so much for the engaging discussion. I look forward to having you back again. Thank you all for joining. For more information about today's topic and to explore opportunities with ChenMed, please visit chenmed.com. We believe access to primary care is a right, not a privilege.